recording in progress. And now I just need to. There we go. I have no significant conflict of interest to declare. What I need to declare, though, is the fact that I have been doing point-of-care ultrasound for a very, very long time now. And since we're talking about the lung, I think it's been around 13 years now. And I was so lucky to be able to redo my course with Professor Daniel Lichtenstein this week. I mean, last week, I just had my bedside training on Friday. And I think that was very cool. 12 years later, to be able to have this refresher course, and actually it wasn't a refresher. It was getting everything, getting back to the basics. And in the meantime, I think he also has, done a little bit of changes, because when you practice, when you teach, you learn a lot. And I was so lucky then to be back on the bench last week. Another thing I have to say, that I have been receiving some honorarium and expenses for some of my talks. It's like a tiny fraction what I do, but there should be no conflict of interest regarding this talk. They're very rare, aren't they? Lung malformations, each individual entity, but as a whole, they actually may lead to a significant burden of mortality and morbidity in the newborn. And of course, there are a number of factors that will influence on prognosis, being, of course, the type of lesion, its size, and how severe the malformation is. For many small lesions, we might not even pick them up because the children remain asymptomatic. And then again, it all depends on where we're working. In my clinical or my context, there is a very good antenatal follow-up. There are even 3 antenatal scans in France. Also, I know other countries with a good quality of care will only scan once, for example. So it really is kind of, let's say, setting dependent. And most of the world's population, unfortunately, do not have access to adequate antenatal care. And this is where, like Alok said, possibly lung ultrasound could be a very interesting tool, in addition to it being interesting in for example, caring for unstable babies with, even if we do have the antenatal diagnosis, but to be able to really give them personalized care. So what kind of lung malformations do we know anything about regarding lung ultrasound? Well, mainly we've got the big groups, like you've got the big group of lung underdevelopment, and then you've got the lung lesions like CPAM, hybrid cases, and if you've got then other things like congenital lobar emphysema, cysts, and so forth. So what if I told you that you can actually use lung ultrasound? But to do what? Diagnose, yes, probably, but also how to use this as a very good tool, for example, in the hernias, to be able to manage care, the patient before, during, and after the postoperative course. So if we take this in a more schematic way, if we try and talk about the lung underdevelopment, that could be like primary, like in pulmonary agenesis or pulmonary aplasia, or we could have situations like pulmonary hyperplasia that could be the consequence of, let's say, for example, congenital diaphragmatic hernia. And, well, in my personal experience, I have not seen that many cases of pulmonary agenesis, but the case I did see most recently was a term infant who had been diagnosed antenatally and who got this chest X-ray after birth. And the reason I got to scan her is because, well, first of all, we decided that it would be good to have her just for observation on 24 hours. And what I'm showing you now is an ultrasound scan of her the left anterior thoracic area. And you can see that we can see the heart really well, especially because there is quite a lot of fluid, which makes it it's a very nice window. But this was basically what we saw. And it makes sense when we go back and see the X-ray. We were not really expecting to see much. And then if we look on the other side, you can see a perfectly normal lung. So basically, we have one part of the lung that has not been developed, and the other one is completely normal, and there would be no reason that this other lung would have any kind of pathology. And there was this deviation then of the heart to fill up the empty space. Unfortunately for this patient, she was admitted a few days later because she had a case of bronchiolitis with coronavirus, not the COVID-19. But this would be the main consequence, the fact that you have lesser lung volumes. And if this one lung gets sick, of course, the area you've got left is proportionally much less. Well, what about what we see most of? We can see a lot of children with lung hyperplasia of varying degrees of severity. Either as, let's say, if we're working with preterm infants, it could be the consequence of very preterm rupture of membranes, especially in, the critical phase, and we end up then having lungs that do not develop correctly. Or we could have the case where we have structural malformations, like in the case of congenital diaphragmatic hernia, where you've got abdominal organs coming up and then making lung growth insufficient. This was just a picture of a poster that was presented at the second launch for the team from Milano, where they showed there you can actually see the lung bathing in the fluid. It's not really often we can see that. Although it's a picture of a picture, I think it illustrates the fact that sometimes you can get very interesting images. So let's start with congenital diaphragmatic hernia. Again, in my country, most of these children are diagnosed antenatally, so we're able to plan for delivery in a center, which has pediatric intensive care and surgery available. And there is a national guide to how these babies should be managed at birth. But this is not the case everywhere. And even here, we have had several cases, or I have had several cases of babies being diagnosed, for example, in the delivery room, because either not responding well to a resuscitation or having some kind of severe respiratory distress not explained by anything else, and where you end up actually seeing bowels in the thorax, which is not where they're supposed to be. So it can be very useful for the diagnosis of congenital diaphragmatic hernia. But where it can also be a very interesting bedside tool, and here there is no literature, this is really personal experience and discussing with colleagues worldwide, internationally, it's could we actually use it to have an indirect estimation of the ipsilateral lung volume, to have an idea about, is there any potential for re-expansion of this lung once this baby has been operated upon? And of course, during the management, assessing for complications, especially then to the good lung, be it pneumothorax or insufficient recruitment, or, again, using it to stabilize the baby preoperatively, because these lungs are extremely fragile. They are to be treated as, lungs of an extremely low birth weight infant. And you want to open up the lungs enough. And there is always this cardiopulmonary interaction because of the way that the pulmonary vessels are maldeveloped, and the left heart is often, at least physiologically, hypoplastic. So there is a number of things coming in. And it's very tempting to put the ventilator on the max and try, and do everything. But that is not necessarily what is recommended. So preoperatively, being able to manage the patient, stabilize the patient enough so that the patient could undergo surgery, and then postoperatively, both to evaluate the degree of expansion of the lung, but also to see whether, there's always a phase of pneumothorax. The air comes in once you operate upon, see how that resolves, and then the fluid that comes in, to be sure that this is not really something that is coming in the way of successful weaning of the ventilator. And of course, I'm sure you've discussed before, using lung ultrasound as a non-cardiac hemodynamic evaluation tool. So the first step here, more than ever, is to be systematic. Must start to look for the bad sign, which means that you should start always in my opinion, by scanning in the short axis, aka longitudinal, because you must be sure that you are actually scanning the lung, and you must be sure where you would expect to see the pleural line. I know that many of the papers out there, even in adult literature, will talk about the long axis with the more transverse, but this definitely, if you are like me and you like to have like a global overview and you like to do both, please start with the short axis, because if you don't, there is always the risk of getting it wrong. As you can see here, this is a short axis view. We have one rib with acoustic shadowing. We can't really see the second rib that well. So we're kind of in the middle of, let's say we've got one intercostal space at each side of this rib in the middle. And if we hadn't been systematic here, we could have thought that this large loop, can you see the hand that's pointing? Yeah. It would be easy if we were not systematic and to say, oh, that's a bit strange as a pleural line, but yeah, oh dear. It doesn't seem to be sliding. There seems to be a lot of muscle movement, and then possibly here at the end, there may or may not be some kind of movement. And if this baby is not doing well at all, this baby is extremely hypoxic or hypotensive, and you're stressed, if you're not systematic, you might be tempted to think that there is maybe pneumothorax. But of course, the pleural line is over here, or it should have been over here. This is not a bad sign. Well, the bad sign, I should have, of course, centered the clip a bit differently, but please bear with me. This is not what we would expect the bad to look like. So this is not really the lung. So this is, for me, really a major point. Even when we're scanning babies who we expect to be really well, I know this has been stressed during the different courses and the peer reviews, but please, I mean, I've just come out of Daniel Lichtenstein's course, so I cannot say it enough times. Always start with the bat. Always start with the bat to be sure where you are and to be sure you know where you should be seeing the pleural line. And the rest, of course, you go systematically. So what do we know about the lung ultrasound findings? I would say basically nothing has been published. There is this paper by Yuri Corsini. It's the only paper, unless any new ones have come in the past weeks. But we don't really have an idea about the lung in itself. However, what is very interesting in this study is that the authors give us some tips on how to assess the hemidiaphragm, and basically, you know, by this view, being able to see whether the diaphragm is complete or not. And then the other signs that they will talk about is basically the fact that in the area, so here will be the left lung over here or the right lung over here, you have abdominal organs, and they say absent sliding in the ipsilateral side. But I would beg to differ. That really does depend on how much the lung is there. But to be systematic again, if you really want to check whether the reason why you have such a strange picture is a hernia, you have to look at the diaphragm too. More importantly, you will be seeing, like here, something strange in the thorax. So you can see that this is not a normal lung on the chest X-ray. You can see this is an intubated baby, and the lung is white on the left side. We could guess that maybe this is the heart, but it's not really easy to get the details here. And this was an antenatal diagnosis. And if we see again here, for those of you who have never seen a congenital hernia on ultrasound before, this is what it would look like. So you have the subcutaneous tissue over here. This is probably a rib that has not been ossified, or maybe the clavicle, I'm not sure. You've got one rib over here with lung sliding, rib shadowing, my apologies. And we can't see the second one. And we would expect the pleural line to be somewhere over here. But what we have here instead is something else completely. These are loops of bowel, right? But we can see that there is this push the lung downwards somehow. But this is most probably where the lung is. But of course, we cannot be sure. It could also be the ring down effects from the bowel. But since I know this patient, I can tell you that this was the lung. So in this case, we can actually see a lung. And when you can see the lung, that means that there has been enough space for the lung to develop at least partially. This is not what you would see in a severe case. And here is another clip. It's a bit turned to be able to catch at once the bowels here, and again, follow this, what we think is the lung surface that's being squashed downwards by the gut. And that is here maybe moving. Here, not easy to say, probably a bit, with multiple B lines. We could also have, well, maybe we'll go to this one over here. This is a scan by Virginie Maupetit, using a completely different approach. As you can see here, she's done, here we go. She's done more of a longitudinal scan, where you can see the heart over here. And here you can clearly see, because nothing is aerated here, right? So you can clearly see the liver, which is up in the thorax. And then there's a little bit of lung that is not sliding over here. And again, this is right anterior, where you can see that we have intra-abdominal organs that are in there. Sometimes, and most usually, this is an isolated malformation. But sometimes we can have it with other lung malformations, and of course that makes management much more difficult. But going back to this one, I said you should do the bad sign. Always start with, we did this here, but then we turned the probe probably around a little bit. But as you can see here, it would also be very tempting to think that this is the lung surface over here. It is not. This is the left thoracic area, and this is, you can see the peristaltism here. So this is bowel movement. So subcutaneous tissue with some muscles. And over here, we don't get to see the bats at any point, but what we see is movement, which is related to, you know, the movement of gas and fluid in the bowels. Peristaltism, which is something you probably would see if you take the time to look. This is a rare case of term baby that was born with two kinds of malformations. On the left side, you have what looks like a large consolidation, right? And that was actually a CPAM. And then on the other side, you can see signs of hernia, the bowels with peristaltism. So in my experience, you can actually get an idea, a rough idea of the underlying lung. Is this really important for the operative course today? In my setting, not at all, really not at all. But I was recently in another country where we were in the NICU, and one of the attendings called us. We were just doing some bedside training for lung ultrasound. And they told us, could you please come and look at this baby? Because, I mean, my colleagues have tried everything. I have to go. And it would be very cool if you could do like some cardiac ultrasound and lung ultrasound to see whether we could change management. At that time point, the baby was hypoxic with SATs around 60% and 100% oxygen and hypotensive. And found out that this baby had left-sided congenital diaphragmatic hernia. I don't have the picture, but I will show you why I'm talking about this. And signs of very severe pulmonary hypertension. And this was really what we targeted first. We tried to give some pulmonary vasodilators, and actually very quickly this baby became more stable with SAT levels above 95%, and we were able to start weaning off oxygen a bit. But this baby then, again, when we had looked at the lung, at the left lung, we actually could see the left lung. We could see that there was a bowel. We could see there was some liver tissue, but we could also see that there was, for the first thing on the left side, some lung tissue that we could see. So the lung was at least partially developed. And on the other side, we could see that this was a well aerated lung. So there was no reason to increase pressures because that lung really was sufficiently aerated. And I find that's very interesting to try and get an idea. I mean, how far can you see the lung when you're scanning? Can you see the lung? If not, it probably is a severe case. coupled with the fact that you can see the liver up, for example. If you can see it halfway, then you can say, oh, that could be probably a baby that will be able to re-expand their lung quite easily after surgery. And if you have, you know, just like a tiny hernia, you can get a good idea. You can even see lung sliding and such. When the surgeons do operate, when the baby is stable enough, and that I know varies from one center to the other, the next question is, well, what happens postoperatively? You want to manage that baby as gently as possible. And you also want to get that baby off the ventilator as quickly as possible. And where I feel it's very interesting is to do the postoperative scans daily, more, of course, if the patient is unstable. And would you agree with me? So this is left anterior. Would you agree with me? This is one rib, the second rib, and this, I assure you, is the pleural line. We have no lung sliding here. We have only A lines here. And in this part of the screen, we do have lung sliding with some B lines. So we have a lung point over here. So there is a pneumothorax. And that is really, I would say, almost systematic because of the surgical technique. So you might be using, your surgeon might be using thoracoscopic approach. So I'm not really sure how that would look if it really does give us large pneumothorax as the open surgery technique. But we usually see some air, and then you can see this air resolving over the days. And after the air, you will see the fluid comes in. There is always some degree of effusion like here, but it's usually mild to moderate, and it usually resolves on its own. But sometimes it is not the case. So if you have a patient that you're having difficulty weaning, a patient that you have followed up, and you see that this effusion is larger than a moderate effusion, and also that, you know, it seems to persist, most probably, as an exception, that patient would need tapping of the effusion. It could be chylothorax, for example, to be able to expand the lungs correctly. The other lung is the lung that we're using to ventilate the baby. And of course, any complication that comes there leads to drastic symptoms or changes in the clinical situation. I remember distinctly one patient we had who had an antenatally diagnosed severe hernia, who was actually, well, we had a mother who did not really want to believe us when we said we thought it would be very difficult for her daughter. But we managed to stabilize her on quite a number of drugs and a ventilation regimen that wasn't easy. And then suddenly she deteriorated around 10 p.m. the first day. And this is what we found on the right lung. So she had developed a pneumothorax on her right lung, which had led to almost immediate bradycardia and decompensation. And luckily, we're able to perform a needle aspiration very quickly, and her heart rate went up. But I must tell you, it was a very tricky aspiration because the heart was all the way into the right thoracic area, and sticking the needle into needle aspirate the pneumothorax was a bit stressful. Sometimes, and when you are very lucky to see that, you can see images like this postoperatively, where you still have a little bit of air, but you also have a bit of fluid, and you have this mixed pattern where on one side you see you have no lung sliding, only A lines, no B lines, and then you've got this lung point over here with a little bit of effusion. So it doesn't really, in this case, tell you more than there is a hydropneumothorax. But since you know the patient, you're able to evaluate whether this has any clinical significance for your patient or not. And another useful use, I would say, for lung ultrasound in managing these patients is, again, to assess the underlying status or the lung condition of the contralateral lung. And I don't know how it is in your centers. I was working in a reference center for congenital diaphragmatic hernia for many years, and we did propose with severe cases antenatal plugging of the trachea, which was, inserted and then usually removed around, I don't remember, 28, 29 weeks, something like that, maybe a bit later on. And the idea is that by plugging the trachea, you're hoping to get some lung growth. One of the main complications or side effects is the fact that these mothers often go into premature labor with, let's say, an average term of 34 weeks gestation, which was the case of this baby I'm showing you. And classically, what could happen is that you're prepared to have a challenging case, but usually these babies stabilize at birth and you're able to get them into surgery after, a little while. But sometimes, like in this case, you're following the protocol and this baby is not responding. So the question then is, why is this baby not responding? Is it because the underlying lung lesion or the hernia is much more severe than we thought and there's a pulmonary underdevelopment? Or could it be that the other lung, the right lung in this case, is also sick? And as you can see here, the right lung, the chest x-ray, everything is white with some bronchograms, right, on the chest x-ray. And when you then look in the inspiratory phase of the right lung, this is a lateral superior of the right lung, and this is the lateral superior. In expiration, you can see how the lung collapses completely with even more loss of aeration in expiration. So we interpreted that to being a severe case of RDS. So she received a half dose of surfactant, which actually changed the clinical course because she did have RDS that we were able to diagnose on the healthy lung. And that was probably why she was having such problems maintaining stable stats. And this is what it looked like. Again, this is a long axis, but you can see how difficult it is for this baby to aerate their lungs. It's a combination of preterm birth. I do not think she had gotten any antenatal steroids. And the fact that on the other side, everything was pushing from this severe hernia. Does anybody have any questions for now? Any comments, personal experience?
Folks, feel free to unmute yourself or put your hands up.
Please do, yeah. Okay, I haven't marketed congenital hernia enough. It is super exciting to scan them. It really is. And I think someday, we need to have a very practical paper on how to manage infants with congenital hernia so that we're able actually to follow the guidelines on gentle ventilation and targeted, really personalized treatments. And once you do the next course ALOC has to offer, you have some cardiac also. It is really all about the physiology, and having lung ultrasound there gives you information on the underlying lungs, if you can see both, or lung. And it does really offer a number of let's say you have a vision into areas where, as you can see, the chest x-ray does not really help you. This baby has an issue. What it is. But how does this really influence the physiology? What does this really mean for your, for example, your ventilating settings? Is it the heart? Is it the lung when the baby is desaturating? I find that to be extremely useful. And again, I really like physiology. So being able to understand what's going on is something that, for me, is important. And I feel that it does help give each patient management as far as we can do today, really answering their specific needs and not a one size fits all, because we know every baby is different, but this is especially true when these babies are admitted for underlying congenital malformations that have had an impact on not only antenatal growth of the lung, but also of the lung vasculature, on the heart, on really the pressure regimes. In my opinion, this is the tool, basically, we should be using today. But like Alok said, there is not much out there in the literature. So basically, we have to share our experience and we have to publish So I'm very happy that you published a paper on that. It was, again, a very simple paper with some information, but I think what would be very useful for us neonatal or pediatric intensivists, those of us dealing with babies, is a more practical approach to, or let's say, try to have some classification of what we see on the sick side and the fact that we can actually monitor the healthy side or the contralateral side to be sure we do not harm that side as much, be it giving too much fluids, for example, over-ventilating or not ventilating enough. That is rarely the case that we don't ventilate enough. And basically being able to ask the question, is it the heart or is it the lung when the baby is unstable. So I see there's a question if we're able to give an idea on the prognosis. Well, antenatally, yes, there's a lot of literature on the antenatal ultrasound follow-up, also MRI if there is an antenatal diagnosis. And there are many different ways of assessing this, but basically there are a few criteria that are being used internationally to have a kind of prognosis, like saying this baby is with probability of so and so, this will be a severe case. The fact that the liver is up is also a criteria of severity. And so this LHR lung to head ratio is what's being used a lot. However, if you are actually diagnosing the babies postnatally, you will not have been able to have this information. So your information on the prognosis of this baby will depend on a number of things. And usually it's not necessarily the lung that is the most important factor. It is more the lung vasculature, because not only are the lungs hypoplastic, but the lung vessels have not developed normally, and they will not react to, let's say, normal mediators or to mediators the way normal lung vessels would, and notably response to oxygen, response to all this. And then you've got the whole left heart that usually in severe cases is severely underdeveloped, but it is not an anatomical anomaly. It is more a physiological anomaly. So you will have, for example, the cross of the aorta. It is complete, but could be very small, and a hypoplastic left heart, but that's physiological. And when this heart is giving some time to remodel, it often starts to work well. So the prognosis is probably more related to this. And of course, how much lung tissue you've got left. And then there's a question, you should be losing lung scoring. And okay, I have a number of questions. Thank you, guys. Thank you for making it interactive. I'll start from Anastasia's question. Hi. Do we intubate every newborn with CDH? Yes, we do that because that is our national protocol, and this is what we do recommend today. If we know that there is a newborn with congenital diaphragmatic hernia, our protocol says that we intubate at birth, because we do not want to, aerate the digestive tissue too much, because that will lead to increased intrathoracic pressure, and it's really difficult to manage them. So in our protocol, it is that you have a senior physician that will be waiting for the baby, that is then delivered, coming in, intubated at once to start ventilating the lung or lungs. And also you put in a gastric tube to relieve then, the stomach or digestive, whatever area you can get, so that there is space for the lung, especially the contralateral lung, to expand. And can lung ultrasound delivery help to understand whether we should intubate or not? I can't really answer that question, because I think today what we think is best is that we should be intubating all the babies. Now, there could be a subgroup of really tiny, tiny little hernias. Or maybe we're not really sure if it is a congenital if there is a defect in the diaphragm, or if it's just, going up, eventration. I think that's what we call it in French. I don't know what we call it in English. That is a subgroup. That is a tricky group, but this is a group that is not urgent, because the babies are doing well. They're cute, they're smiling, but babies with congenital hernia don't feel that good. and they should be in our setting. Our recommendations say that they should be intubated, even if we expect them to have a mild form. And then lung ultrasound would be very useful in assessing the lung status, lung aeration, but we would not use it today to make the decision whether we should intubate or not. And then Dr. Ashraf is wondering whether we can assess the severity by using CDH lung ultrasound score. It doesn't exist today, Dr. Ashraf. So I think it would be very interesting to think what you should incorporate. I think that it would be possible. I mean, scores are a la mode, but a score that's really practical and easy to use that would integrate at one point, you know, the organs, if you've got liver up or not, if we can see the lung and how far it goes, and a number of other things also related to PPHN and so on, I think it could be extremely interesting. And Alberto was wondering, how can we differentiate from severe RDS versus severe hypoplastic lung? Because surfactant is not indicated except in premature babies. Well, surfactants is indicated, of course, it all depends on what we've got in each country, what the surfactants, how do you say that, on the notice when you have what you're allowed to use the drug for?
Licensing.
Licensing, yeah. It's usually licensed for RDS in premature babies, but that doesn't mean that we're not using it in RDS in term babies, for example, or in meconium aspiration or in other things. So you would say we need to be able to see the difference between severe RDS versus severe hypoplastic lung so that we don't overuse surfactants. I think that the case I was referring to is the contralateral lung. It is the healthy lung. And I wouldn't be able to tell you whether the sick lung, you know, the one that is on the side of the hernia, usually left-sided, right? Whether the lung looks non-aerated because it is compressed, because it has not been developed, as in hypoplastic lung, or whether there is an addition, severe RDS, but RDS should be both sides, right? You should have surfactant deficiency in both lungs, even if you have a hernia and a plug. So I would say that the only interest in giving surfactants, it's an exception that we do that, but the only interest would be in cases where you have a baby presenting, a CDH baby presenting with RDS that you would diagnose on the presumably healthy lung, and you would only give half the dose because this is the lung you're targeting. We don't have any criteria on how to actually diagnose a severe hypoplastic lung, because if you see the lung, you will still be using the same artifacts. We don't really see the lung. We're just seeing the artifacts that arise as a reflection. So we are able to make assumptions on the underlying lung because either we're not able to ventilate it because it's really, you know, compliance is different, or we're having really severe issues being able to open the lung up. But if the lung is open, it's not easy with ultrasound, at least I don't know the criteria today to say whether it is hypoplastic or if it's something else. But going back to the RDS question, you would only give surfactant to a baby, usually preterm with CDH, if the contralateral lung shows signs of severe RDS. And of course, if clinically you have a problem. So that would mean that if, and you wouldn't expect that, but let's say you also have a hypoplastic contralateral lung, then, I mean, you would have to see the worst case, you're giving some surfactant to a hypoplastic lung. You won't get any, I mean, the response will not be sufficient. There's a question from the Corniche audience. Can we use lung ultrasound score to review lung recruitment in the normal lung, and how do you do that? And whether we do x-rays or not, especially if they're on high frequency. congenital hernia babies are really difficult to manage, aren't they? And we're learning now that we should be more and more gentle. I know that during my years, we were not ventilating that gently. We very easily were in high frequency, and we were recruiting saying, it's okay. But I understand now that we should have been, let's say, much gentler. I think, I do not know if you can actually use a lung ultrasound score to review the recruitment, but you can use lung ultrasound to see the patterns of aeration. And the question is, what do you mean adequately recruited lung? Of course, you would not want in these babies, they're usually supine, right? If you have your A lines in your anterior chest walls, that probably means that your lung is sufficiently recruited, right? If you have even a mix of A and B lines, because of course they're still transitioning anyway. So it's not like in adults where, 3 or more B lines, you know that you have, some decreased aeration. This is a newborn, often in the transitional phase. So the number of B lines is probably more difficult to assess than the patterns, the absolute patterns. So if you have a pattern like a B profile where you've got your lungs, you've got multiple B lines, and if you're using a linear probe, you won't be able to count them, so you see them as confluent B lines with lung sliding. This is definitely a lung where you want to recruit more. Whereas if you have a mix of A and B lines, you're probably going as good as it can get. And we don't do chest x-rays to handle the baby more than maybe once every now and then, meaning that since these babies will get their lines in, they probably get a chest x-ray to start with to get, how is this baby doing at birth after we stabilized it from the delivery room to the NICU. And then, of course, depending on baby's needs, we could redo that, but it's much easier to, like you're suggesting from Corniche, to follow the baby up with lung ultrasounds. Where I had difficulties answering is whether we have an adequately recruited lung. I would be scared of going overinflating that lung, because you risk to have pneumothorax there, and then you're in a very, very bad situation. So I would say that if you have A lines in your anterior chest wall on the normal lung, so the contralateral lung, don't recruit anymore. Try to see more what you can do from a hemodynamics point of view. However, if your lung is completely white or showing you signs of, or consolidated, which is really rare though, it's usually more B-line profile. You could try and change your pressures. You could try and see, like in the case with the baby, if there are enough signs, for example, to think that there could be another underlying disease like RDS, although that is rare. So I guess my answer to Corniche is you can use lung ultrasound to review lung recruitment in the normal lung. You can start with doing your first scan when the baby comes to the unit, and at that point, you will also get your chest x-ray with your lines and everything. And then depending on what your baby's needs are and where the baby's, clinical condition takes you, you can recheck every time you do any changes, because in the beginning, you need some time to find out what the baby needs. And of course, the SATs, if you're using blood gases, and then go back and recheck. If you've come to a point where the normal lung is showing you A lines, even if there are a number of B lines, I would say that you have adequately recruited that lung. If, on the other hand, you're still having problems with this, then maybe, at some point, especially if you're decided to take your baby on high frequency, do a chest x-ray again, just to be sure where your level is, that you're not missing out on the fact that you actually may be overextending something. I don't know if I was clear with my answer.
Yep, no, absolutely fine.
Yeah. Can we differentiate a lower hypoplastic lung versus a pleural effusion complication? Yes. The effusion is an effusion, and that will be, between the pleural leaflets, you'll be able to see. You'll have the quad sign. You'll have, I know, Alok, you have the talk on effusion, right? So the effusion, unless it's a complicated effusion, the effusion is usually quite a few effusion, right? that will move, that will be dynamic. Whilst hypoplastic lung, it doesn't have any specific pattern. It's just a hypoplastic lung. It's lung tissue. It's just smaller, or it's developed incorrectly somehow. So if you do see the lung, you will see that as either a part of a small lung that is, or just a normal looking lung, depending on the degree of aeration of that. But effusion would look like your standard effusion using the same criteria that you would use to diagnose any effusion in the newborn. So would you, oh no, there's another message. Oh, great. Maybe we could go on then to talk about some of the more rare complications like CPAM. So cystic lung lesions, basically. We know that there are multiple types, right? And depending on where, what part of the airways they have started, which type they are, we can have different lesions. And by themselves, I mean, they can be, depending on how large they are and where they're situated, they can have different prognosis. Then we've got the form of pulmonary sequestration, PS, which is the variant where you actually have a systemic blood supply. And this is a condition where we have some literature from the radiologists, because they're the ones that scan the babies that have that. And of course, you can have hybrid forms, so cystic lung lesions and lesions with systemic blood supply. In themselves, they're quite a large group of pulmonary airway disorders. And many of these children, especially in the CPAM, will go on to do really well at birth. So again, in France, we see these babies and we check them up on birth because we have an antenatal diagnosis. And most of the times, these babies just go home with mom. They're doing fine, and they're followed up by the surgeon. Because in France, at least, there is a tendency to want to operate on these children in the first years of life to try and prevent malignant transformation. What is very specific for CPAM is the fact that they are cystic lesions. And I'll show you the different forms that you can see. But basically, this is the only neonatal congenital, or the only neonatal cause of respiratory distress that presents with cystic lesions. It's not the same in adult medicine, of course, but if you do scan a baby's lung and see that you have areas with what you suppose are 1, 2 more lesions, then please do a CT scanner and please think of the possibility of a CPAM. There is no other diagnosis that gives you that picture. And there are no real studies either. There is a series of few different papers, but they're basically series on newborns with CPAM. And this is the one we published. So it was to show that there was a good correlation in these children with the CT scans, because these were babies who were symptomatic. They were admitted to the NICU because of respiratory distress and or hemodynamic compromise. And this term baby, for example, you can see on the lung ultrasound scan, so we've got almost 2 intercostal spaces. It looks like tissue, right? It doesn't look like the lung. And then you've got multiple darker areas, which are the cystic lesions, and they're communicating some areas. And you can see here that this is exactly what we saw on the CT scan. So you've got multiple cysts, and the heart was really deviated, which was really why he came into the NICU, because he had severe pulmonary hypertension. And then you can have this form where you have just one mega huge cyst. And this was a baby who was initially doing very well at birth. And then she was feeding normally and everything. And then she started to become dyspneic and not doing so well. So she ended up in our NICU. And it's probably because this, this cyst got so aerated afterward, though it was really pushing on the rest with the deviation, a little bit of the heart and a little left lung. So what we could see was this mega area, which was supposed to be a mega cyst. And then this third one is completely different. He is interesting because he was a twin who was born at 25 weeks. And this was like, this is usually the time where proportionally, at least your lung lesion is at its maximum. And for him, it took up most of the left lung, and it looked here very unspecific, like a consolidation. And his complications was the fact that he has numerous super infections. But then he ended up, in addition, of course, to RDS, and, you know, he was a very preterm boy. And when he did get his CT scan a few months later, you can see that the only thing that was left was this consolidated part of the lung. And he's 12 now, and he's doing well. He's never been operated upon. And these were really the antenatal scans also, that you're able to see pre and postnatally the different cysts, so that you can really see them quite well at birth. This was the girl who had this mega cystic lesion. Other teams have also published, and it is really the same thing. The conclusion is you can pick up cystic lesions, but of course, we don't know if you can pick them all up. And I find this paper to be interesting because if you look at this chest X-ray, at first glance, I probably wouldn't think there was very much to it, really, maybe, possibly, unless I look really well here inside the circle, and then I go, oh, yeah, maybe there is something. And you can see on the lung ultrasound scan that it's not very specific. You've got normal-looking lung on each side of an area with multiple B lines and a small consolidation. So there was some contact with the lung surface, and this is what the CT scan looks like. And since then, I must shout out to our colleagues in Vilnius, if any of them were connected, but they just presented a case a couple of weeks ago on a small baby boy with congenital, with CPAM, and the lung ultrasound findings were also very discreet. There was like a small consolidation that they did follow up, and it didn't go away. And also very small changes on the chest X-ray, and they ended up finding it on the CT scan. So you don't necessarily have to have huge changes, but if you do have any changes with cystic lesions, please think CPAM. And the second message is, if you have something, this is not really huge, and the baby was doing okay. But if you have some lung lesions that you cannot explain, please ask the patient to come back and follow up. And at some point, do a complementary imaging technique if this does not disappear, because there's no reason why a baby should have these areas. I mean, unless they're like a 24-weeker with severe BPD and still, needing help. Although if it's always at the same place, always unchanging, that would not make sense with, a chronic lung disease in the preterm infants. This is not video, but this is a baby who had pulmonary sequestration. It looks like solid tissue over here. You can see it again here. And here. And basically what you need to do is then, once you have seen it, you need to find out where the main vessel comes from. And I must admit, it's usually the pediatric radiologists who do that. They teach me a lot. So I think I have a lot to learn there also. Sometimes you have mixed cases where, as you can see here, you've got the multiple cystic lesions over here, and you can end up having an area where you have this systemic vessel coming in. And it's important for the surgeons also because of the decision to operate or not, and what to do, or whether they want to embolize, right? Like here in this case of sequestration. So basically, what do we know today? Well, we know that we can use lung ultrasound to make the diagnosis, but we don't know if, especially in the case of CPAM and in smaller malformations, we can't really say the percentage. Are we capable of seeing 99%, or are we capable of seeing 60%? This study has not been made. They're very rare, each on their own, but of course together. They're a large group of pulmonary malformations. The second thing I would say is that if you do find something, like especially if you do find a cystic lesion in the lung of a patient or somebody presenting with respiratory distress, it should lead you to think, I need to rule out CPAM, because there are no other neonatal conditions that show that. So I would say that I would think it could be a very valuable tool in low resource settings where you don't have access maybe to antenatal scanning. And if you then do have a baby or a young infant coming in with respiratory distress and you find these lesions, that they are transferred to a center with either radiological or surgical competence. Of course, you would not pick up the ones who are asymptomatic. When it comes to congenital hernia, I would say that for me, this is the tool to manage a patient who who's complicated to manage, and where we know that one size does not fit all. It gives us valuable information on not only the lung aeration, but also changes to like the questions we saw today. When we change the ventilation, is this lung adequately ventilated or not? My patient is not doing well. Is there a problem with the lung, especially then the supposedly normal lung? Or, you know, is there something I should be looking at from a hemodynamic point of view? Because this interaction, when you do increase ventilation, you have a response when it comes to your venous return, because the pressure regimens are so strange. I mean, even to do the heart scan, you have to go looking in the right axilla. It's complicated. So it gives you insight where you would not be able to get this information by any other means. I mean, one, we're not taking these babies to CT scans. Most of us don't have MRI bedside, although I'm dreaming of having it one day. And then chest x-rays, again, they're just white or not white. So they do not give you as specific information. And when you know your patient's lung, you can follow them up and you can see what the difference is. Even if your patient is not sufficiently stable to go to surgery, and whatever your national or institutional protocol is, lung ultrasound gives you information you cannot get otherwise. Maybe I think the first step would be to share experience, because I think either it has to come from a high volume reference center with people who have expertise to, let's say, do both the management of babies with hernia and lung ultrasound and other points of ultrasound. I think that would be ideal. But still, in the end, even in the big reference centers, how many babies do we get each year? So I think it would be very interesting to have more than one center. And then think about maybe what, like Dr. Ashraf said, should be, are there some criteria that are more important than others? I have the feeling, again, this is my personal experience, and I did not scan 3,200 hernia babies, but it seemed to be that if you look at this lung before surgery, once you've, more or less had the time to get your baby to the NICU, to have them on the ventilator with settings you're more or less happy with, the baby is more or less stable, and then you do your first scan. If you can see the lung, it's of course better than if you cannot see the lung. And if you can actually see the lung starting to cross, let's say, the middle clavicular line, it probably is not that bad. If you see just like a tiny, tiny part of the lung, it's probably more complicated. And of course, if you see more than half of the lung, then probably, unless there are other complications coming in or it's the hemodynamics, although it shouldn't be that bad in that case, I feel happy when I see that. I'm saying it doesn't look like bad. There is hope. And then Alberta is wondering, is there an optimal time to do a lung ultrasound scan in babies who already have a lung lesion? So I would say the babies who have like a suspicion or a confirmation antenatally of a CPAM or, sequestration, yeah, you can leave them 1 or 2 days, because if the baby is doing well, that will not change management in any way. What you want to do is to see whether you can confirm the diagnosis or not. And you will probably do a chest x-ray again, because we don't know how many CPAMs we can or would miss or not miss using lung ultrasound. So yeah, I would say first, second day of life, maybe, but by first, I mean, this is not a priority. The priority is the bonding between mother and child, that the baby just, be okay. And then maybe the next day before discharge in any event. And again, in France, the mothers stay at least 2 days at the maternity. So if you are in a country where the mothers are discharged 6 hours later, like maybe in Sweden, you would do that before, right? as your checkout, and then recheck when the baby comes back for their well baby examination around 2 days of life. So I think there is, another thing that could be interesting to do is, especially for the CPAMs, in my setting again, these patients undergo surgery at some point, and the surgeons will program the CT scan like it's protocolized. But what if we did, the scan, lung ultrasound scan before? Maybe that could help us to know when the ideal time of doing the CT scan before surgery would be. I'm talking about this 25-week twin. He had been admitted to do his CT scan and everything in 2 years. And basically, it was not possible to, he just had a tiny lesion and actually had 2 lesions on the another one. And I was thinking, I was following him up with lung ultrasounds, and I could have told the surgeon, that there is not much there. So I don't know. I think this is interesting to see the potential of. I would say probably even more in babies with congenital diaphragmatic hernias because of the practical implication, because these are very fragile babies and we want to be giving our best care possible. Doesn't mean that I don't think that CPAP babies don't deserve the best. They do, but most of these babies are doing okay. And when we have to deal with them, it is usually when they are not okay. And then we'll be in the same, situation where we need to act quickly in a pertinent way and coordinate with surgery. So I'd like to thank you all. And if you ever are in Paris, please come for a visit. And I'll also take the opportunity for those of you who are French speaking, or for those of you who do come to Paris once in a while, just to let you know that we have a French interest group for pediatric lung ultrasounds. It's called Groupe GEP, Groupe d'Échographie Pulmonaire Pédiatrique. And it's multidisciplinary. We're all pediatricians, but many are, pediatric pulmonologists. I'm a neonatal intensivist with Virginie. You've got pediatricians working in the emergency room. And the idea is to get lung ultrasound out there to the pediatric community and to do training, courses, research together. And we're happy to be collaborating also with POCUS UK, for example, and with the ESMIC. So this is the French interest group. For any of you who are in French-speaking countries, just scan us and become a part of our group. Please, we need you. And any questions? I'm happy to take them now or afterwards by mail if you want to.
So, Nadya, I had a question. I've never diagnosed a nematocele. Like you get post-staphylococcal, post-Klebsiella kind of infections. I've never ever diagnosed it. And I just was wondering whether there's any literature or, kind of any image characteristics, or what's your experience?
Well, I haven't diagnosed either, but, I've diagnosed a few abscesses, stuff like that. And I know that adult patients who have emphysema, for example, you can see that. I would think they probably, if you don't have much fluid left and you're thinking only of an air-filled space, right? I would guess, but I don't know the literature on that, but I would guess that it would be kind of like if you have emphysema, not subcutaneous, but you have like a bulla or something, that you would, it would look kind of like a pneumothorax, but you would still have some degree of lung sliding.
Sliding would be present.
That is at least what I understood from Daniel Lichtenstein, though. That would be really the interest of really looking well at your lung sliding. And it's, we agree, lung sliding is a yes or no question. It's not like it's diminished, maybe yes or no, but it's yes or no. So that would be, for me, I think, the difference. And it would be over the area where you have it. And the trick would then be to, like, if you find this and you're like, do I have lung sliding or not? This looks suspiciously like pneumothorax, and you're using the M mode maybe, and, you're starting to move around and see if you find this lung point. But you would also go downwards. You try to get an idea of how large it is. And it probably, if your patient is okay, it wouldn't be that large. So I think it would be more like a more or less well-defined area. What do you think?
I suspect you're right. possibly
Mhm.
seeing sliding with kind of an A
Yeah,
profile.
it
Yep,
wouldn't be as good as the other side because you would check both sides, right? You would
yep,
get an
yep.
idea
You'd
to
get a
try and
comparison
compare.
to see if
And you
it's
would
different.
see there was a difference, but you would not, I guess, think that there was no lung sliding. And if you then suspected abolished lung sliding, then of course you would have to do the chest X-ray and then you would see it, I guess. Yeah.
One more question that has come up, and just on the kind of topic of CDH in particular, it would be very interesting for us to be able to do some work on, the lung that's hypoplastic to see
Yeah, for
and
sure.
look at kind of prognostic outcomes for management, because
Yeah.
we do get lung head ratios done
Yeah.
before birth. But it's just interesting how we sometimes get babies who have got awful lung head ratios who do so well, and then you
Mm.
get the odd baby where they've said the lung head ratio is
Yeah, this
absolutely.
is a cool case, and the baby just does not respond, right? Or after surgery goes into hypercapnia or has really issues. Yeah. No, I think really when I now I don't work with hernia babies anymore. That makes me really sad because again, I find that to be extremely challenging and interesting. I really like that. And what I found to be very interesting was, like I said, to start off scanning in the beginning, getting an idea of can I see the lung, yes or no, on the sick side, right? And then trying to find out where is my lung limits,
Hmm.
laterally. And then try to see whether I thought this would go well afterwards. I mean, is there a potential for re-expansion, re-aeration or not? And of course, depending on what you have inside. I mean, if you've got like huge liver and everything, usually you don't see much. Sometimes you don't even see the lung. But I was surprised to see that even the presumed severe cases, kind of your experience, Alok, uh, many of them had undergone plug treatment before.
Yep.
So, but I still managed to see the lung, at least halfway there and actually aerating. So not just like a consolidated lung. So I would think these would be criteria. How far does your lung go? Is your lung able to be recruited? By recruit meaning at least you see B lines, it's not consolidated.
Yep.
For me, that would be factors of, let's say, moderate to relatively good prognosis. And if
Hmm.
you don't see the lung at all, usually it means it's really difficult.
Hmm.
Doesn't mean that your baby necessarily will not make it out of the NICU, but it means that lung capacity is really reduced. So I think working on that, and maybe like Dr. Ashraf said, thinking about other things to take into account, but I was looking specifically at that. Where is my lung? How large is my lung? I'm measuring it more as, how lateral does it go? And then comparing it postoperatively every single day to see how far it moves out. And you could see at some point, it stops.
Hmm.
It doesn't go further out. And this is kind of, at least, I mean, the babies then grow afterwards, the lungs grow and so on. But at least in the postoperative course, a pretty good idea of how far they've gone. And that would also be the liquid around it and so on, the fluid and so on. So I would think working on that could be interesting. So is the lung aerated or not? Meaning, is there a capacity to open up? And then how far does it go? And then follow that up postoperatively, right?
Seriously.
And
We've
asking the surgeons, what did you find? I was like, what did you
Yeah.
find? What did you find? They're like, yeah, same thing too. So yeah.
So last year we started the FETO program over here in the
Oh yeah.
Corniche. Yep. And so far they've done 6 babies.
Mm-hmm.
So on average, we get about 12 to 14 in a year. And
Yeah.
it's still in development. We were quite nervous when they started because, we always worry about that mother going to preterm labor. And then you're faced with having to have a balloon that's not taken out. So we have ENT on standby.
Believe me, I've been there. I've done that. I do not recommend it. You cannot get that balloon out. It's no fun at all. But you have ENT.
Yeah.
Very good.
So I'm going to ask the audience. So feel free to unmute yourself, folks. Do you have any questions? And this couldn't be questions from previous topics that we've discussed. So feel free to unmute yourselves, folks. So just while people are having a think, I have one question on lung ultrasound scores in RDS at the moment. Uh,
Mm-hmm.
I don't know if you've noticed, but on Twitter, we've been having a huge debate today. Uh,
I've gone off Twitter. There was
oh
too much
dear,
on Twitter, so I
because
couldn't take it anymore,
yeah. So
especially since the recent events. So I'm off.
I mean, in
What
terms of
part of the
work,
debate?
there's a huge amount of kind of debate going on about naturally the European respiratory guidelines produced by SWEET. They've endorsed lung ultrasound.
Yeah, they have.
Surprisingly for me, the Americans uh, who've just produced guidelines on it have kind of stopped short, which was really surprising considering we've got 7 randomized control trials. We have a good group of preterm babies, extremely preterm babies. I know that there's a little bit of debate about we don't have enough 20 to 23 weekers, but clearly, the AAP has now produced guidelines about differentiating RDS and TTN, and very good criteria for it. So my question at this particular point is, I was surprised. I got a little bit of backlash on Twitter today
Oh, you
about
did?
use of lung
Sorry about
ultrasound,
that.
and that
Yeah, okay.
it's not evidence based, and that
Okay.
we need to wait for outcome data. Now,
Okay.
my argument is that when we use clinical science chest X-ray and FiO2, we've not necessarily demonstrated outcome data in that particular group to start using FiO2 thresholds. There have been no randomized control trials to the best of my knowledge. Do you know of any comparison studies?
No, I know about this Australian study where we have the 30% FI2 cutoff. And I always like to think about what Francesco Raimondi says. And I sometimes ask the question. Then again, I don't know if the debate included the use of chest X-rays or not.
It did.
But
It
it did.
started that
So
way because
I would just say chest X-rays, when was that ever validated for the use of
no,
diagnosis of RBS?
and that
We
was my
studied
argument.
usage after less than 100 patients. That doesn't mean that lung ultrasound is magic, but I mean, let's compare what's comparable. Chest X-rays have never been evaluated. We do not know the diagnostic performance of chest X-rays for RDS, especially with different terms, because these papers came out before any 22, 23 weekers were surviving. FI2 levels or thresholds, we know that these are very individual, and in any case, we know that they do not accurately represent tissue oxygenation. And we do not know for outcome-based more than what we know in the meta-analysis by Badayu, that we've got like this 2 to 3 hour, the first 3 hours of
Window.
life, the window.
Yeah.
Maybe we'll have more meta-analysis. So basically, what we need is a tool that can help us screen, because selective surfactant is bad. I mean, a preventive, whatever. Prophylactic surfactants is out because it's not, I mean, at least the fact that many of our populations are receiving steroids, they're not the same babies. So basically, we're in the situation where one, we need to kind of have some magic powers to decide who we're giving surfactant to or not. And today, I don't know the US guidelines then, because I understood that each institution has their own kind of policy, although there is some underlying. So again, we cannot compare what is comparable. If the institutions, if the country, I think you said it was US, if there is no consensus, of course, adding another tool will be difficult. I think the question is just completely different. The question is, what do we need? What does this baby need? This baby either needs surfactant or does not need surfactants. And what do we need? We need to have a tool that can make us distinguish between those who actually do need it and those who don't need it. Ideally, that would be to have some measurement of the intrinsic surfactant, but we do not have that today, at least not at the bedside. And we need to have this early on if we are to believe the data out there, evidence-based. So we need a bedside tool that is accessible 24/7 for neonatologists, who are the ones who are making the decision to give surfactant or not, so that we give it to the right babies at the right time. And this is it. Which other tool do we have? It is not a perfect tool, but we do not have any other tool. And it is not 100%. It is now with Francesco Raimondi's little FI2 over SpO2 is up to 92%. But okay, you have a 10% margin of error. Okay, it's big.
But that's the case with clinical science and X-ray as well. Because look, when we do an X-ray, and a very good example is at the moment, most of our babies over 27 weeks are getting away without a tube. I'd say still over here. Yeah. And that's a group of babies where naturally there's a good opportunity for us to give surfactant to the ones who really need it and not try and keep the ones who are kind of peeped. So an early lung ultrasound there, is beneficial. But in our setup, it's also very important because the parents have to pay for it. It's very expensive.
Yeah, of course.
And, you don't want to delay the surfactant because the longer you delay surfactant, the less efficacious it is later on. So I would say that it's an additional tool in the arsenal. But one of the other big benefits that I've seen is we have babies in this group who might have other pathology. I've had the odd baby, he's got a pneumothorax. Now,
Mm,
actually, it's spontaneous. I've got A profiles on the opposite side. I've drained the pneumothorax and I've got well aerated lung. So I've not necessarily had to intubate the baby.
mhm.
You can get away with surfactant, so it can help you diagnose alternative pathology. And then there are, the babies who are 34 to 36 weeks. We've stopped giving antenatal steroids to the mothers. Again, the differentiation of TTN and RDS, in those babies, hugely beneficial. And that's a group of babies who will take a lot of surfactant if you had to give it to them. So
But are you
yeah,
talking about, is this debate on the lung ultrasound scores or is it on lung ultrasound as a technique?
both. So
Both.
yeah, it was
Okay.
because I started off by kind of talking about the sensitivity and the specificity of
Mm-hmm.
lung ultrasound in the diagnosis of RDS versus chest X-ray. And we know
Yeah.
chest X-ray is very non-specific. And I think, it's then come on to, well, do we have enough evidence to start using it in routine practice? And I would think so. If you can use
Well,
clinicals.
how much evidence do you need, right? Like you said, I mean, we don't have that many babies, but we have more than 1,000.
Yep.
And we've been using chest X-rays for how many years now? We had less than 100. We're getting better. Do we want 2,000? What is the cutoff? How many babies do we need? And yes, of course, we don't have enough 22, 23 weekers. We don't know if the score has to be a bit different for the. We agree. It's not perfect, but
Yep.
what other tool do you really have? But no, I'm just happy there is a debate because 5 years ago, people were like, what? Lung ultrasound?
But I mean,
What?
just an
You
analogy
know,
that
the
I'm,
first paper that was, the Brad score paper. You know what the reviewer on one of the first journals we sent it to was rejected. I think it was pediatrics. Don't remember. Anyway, the thing was exactly in the spirit of what you're saying. The reviewer said, "Okay, I cannot accept this paper because well, two different reviewers for two different journals. One of them, I don't believe in this, so I'm not going to say yes. Never mind. Second was, but this is not 100% sure. How can I condone something that's 100%, not 100% for babies? I mean, no. The performance is not good enough. It has to be 100%. That's why I'm saying no. And you're like, okay, but there's one thing that exists in medicine that is 100%, is that potentially we all die, right? If we're born, we all die. That's the only thing that's 100%. So, I think it takes time. And the fact that you've managed to get a debate on, even if, you were not very happy with the outcomes, is a huge positive sign. It means that people have heard the word and there's enough emotion generated that people actually take the time to answer. And maybe
uh,
in a year or two, we can re-ask the
yeah.
question.
I mean, my arguments there were that we had only 700 babies for therapeutic hypothermia through randomized control trials,
It's
and
been
Yeah.
justified by clinical
it's been
logic. It's been counted.
kind of uh, taken up globally at that time. I mean, we've had a few more trials after that. But then my second argument at this particular point is that if you look at, we've got 7 randomized control trials with a huge range of babies from 5 different countries.
You have
If
7 randomized control? No, we don't have 7 randomized control. They're not all randomized controlled.
some of them are observational,
Yeah.
okay. But even with that, there are
Yeah.
no trials for, if you look at FiO2, it's all
Oh, no, no,
observational
it's
data.
all. You have this one study, and everybody agrees that why 30? Why not like 32 or 27? It's the best we can do today, and that's fair enough. But again, FI2 and chest X-rays are influenced by your PEEP, and work of breathing is influenced by your PEEP, and then FI2 is influenced by,
Pathology,
and then
pneumothorax, pulmonary
and then we go
hypertension.
back in. Your PEEP is influenced by your,
But
by FI2. So
I'm just giving you an example. I've had a preterm baby who, because 24 weeker,
yeah.
intubated, ventilated, and delivery suite. Now, we give them surfactant there. It's our policy
Mhm.
uh, because we have great distances, their transport, all of those things. But this baby's FiO2 never came down. Now,
Okay.
the question from my perspective at this particular point is, well, he may be eligible for another dose of surfactant. Let's have a look at the lungs.
Mhm.
And I was pleasantly surprised. I had aerated lungs. I had A profiles, with a kind of a few B lines. I looked at the posterior
Very
zones.
nice aerated lung,
Yeah,
like 24 week. If you see that, you're just super happy.
So the real debate is, well, where is that coming from? Now I've done an echo and I've got significant ER. I've got a duct that's, bidirectional dominantly right to left. I've debated, I've consented the parents, we've started nitric and we've had a good response. We're down to 25%. Now, naturally, because the parents will have to pay for a second dose, it's helped me identify in a really nice way that there's an alternative pathology that explains my oxygenation, which means that I don't have to get the parents to pay for that second dose. So there are benefits beyond that. I've had a similar kind of a situation with a baby again who's had the first dose of surfactant. We've done the lung ultrasound and we've got a right-sided pneumothorax. Now, giving surfactant to that baby will actually make the baby worse, considering I've got a pneumothorax. It'll reduce lung compliance. I've treated the pneumothorax and the baby has actually improved significantly. And this was a 30-weeker. So actually, we didn't need another dose of surfactant. We were able to actually extubate that baby. So
I think you're taking it beyond that, right? It's a question of perception, right? Is how could you in 2024 accept to treat a patient blindly, even though you have an imperfect tool that you could be learning how to use? How could you accept that? It is not acceptable for me as a healthcare professional. It doesn't mean that this tool is perfect. It does not mean that it will give me all the answers. But this is what I felt 12 years ago when I I had already been dabbling with lung ultrasound for a couple of years before I went to his course. And then when I saw he did the Blue Protocol bedside, and I went back, and the thing was, how could I not learn this technique? It changes the management. I couldn't live with myself. I have to learn this, right?
And you've demonstrated really nicely through the ESTHER protocol that actually you can treat these babies earlier, identify the ones who need surfactant earlier. We're thinking of a very similar kind of a quality improvement project for babies between, like, I'd say 27 and 32 weeks, because we unfortunately intubate most of them below that. So, but that's a group of babies where we can really improve whether they need surfactant, but also for the ones who don't. And, at the moment, we're trying to think of a protocol of how we're going to do that in terms of the timing.
Are you doing salsa or something
No.
like
So
that?
for us,
No.
it's LISA. We'll use
It's
LISA
LISA,
catheters.
okay.
So, and that's the other benefit. We don't have to tube them and put them on the ventilator. Some of them naturally, I would say that, again, lung ultrasound, there's a little bit of influence. If I've got high scores and bad lungs, I might opt not to LISA that baby, but actually tube him because he might need another dose. So there are influences beyond just the evidence that I think are coming into my practice that definitely influence how I might manage individual babies. So,
I think we're still at the beginning, though, although we feel that we've kind of exhausted the subject of lung ultrasound and surfactants. I don't think we are. I'm also wondering where we're looking at it from the right angle. I think the most important information is the information you're talking about. To deprive a child of a technique that somebody is trained to do that gives additional information that may change the management is wrong. It is wrong. And I'm not here saying, please give your surfactant if you have a BRAD score above 9. That is something extra. That's like a bonus thing, use it or not. But you have an imaging technique in a fragile baby, and it is the only bedside tool you have that gives you this information correctly. And it is just pattern recognition. If you have pneumothorax, please, it makes a difference. And like this 24-weeker, many of these babies have it's more hemodynamic assessment. It doesn't mean that I would tell you don't give them surfactant if that is what the guidelines say, but you would understand how you would manage that patient later on. And in this case, it was for a second dose. And this debate for me, the one you were talking about, does not make any sense to me. It's not a question of yes or no. It is a question of how, because we need the tools, and we're all in the same situation. We are faced with situations where we also do things without having the adequate tools. We need to find the adequate tool. This one seems promising, and this one is, the one we can use for now until maybe somebody has this ingenious idea of having something even better. It's giving the best you can at the right moment. So I agree with you. And I think what would be very interesting, Alok, is if you did this study, because most of the studies are coming from the same centers. And at some point, you need to have this validated in other centers and see whether it makes sense to use somewhere. we're not all in a level 3 in Italy or France or Spain, right? And we don't work the same way, and we do not have the same needs. And we really need to see whether it is something that can have an added values in other clinical contexts also maybe in countries where you don't have surfactants, where the question would be different, right? So that was for me what's exciting. Yeah.
I am gonna take this opportunity to thank Nadya. Anybody have any last questions? Alberto, Ashraf, any last questions? Okay. So thank you so much, Nadya, for being with us today and taking your time out to kind of talk to us on a topic that's incredibly, I would say important, but for which there's very little literature. We will be having a further talk from Nadya on collapse and the use of the Safe and Safer protocol, which is, I think, on the 31st of this month. So we look forward to meeting you at that time. God bless you. I've got a comment from Praveen. Many thanks for today's talk and interesting discussion, Nadya. The valuable evidence base you have created for lung ultrasound in neonates is convincing more and more neonatologists about its immense value. Alberto, thank you very much. Fantastic presentation. Absolutely. I agree 100%. Thank you, everyone, and God bless you all.
Thank you, everyone. And I take the opportunity to, I don't know what you're celebrating, if it's Ramadan, if it's Palm Sunday, if it's, I don't know, Ruse, if everything. It's so great that so many celebrations are together. So take care and see you next week.
There's a question from Ashraf, Nadya.
Okay. Is there a protocol for 22 weeks? What do you mean, Ashraf?
I mean, the clinical guidelines.
Clinical guidelines for 22 weekers?
23 week, because there's a lack of this age group.
If there is what kind of clinical, surfactant protocol?
No, I
Yeah,
think Ashraf is saying that because the lung ultrasound studies, contemporary ones, haven't really looked at large numbers, the question is, are we okay applying the lung ultrasound scores as they're described in the literature to that group of babies?
How do you feel about that, Ashraf?
I think you can use it.
I
Hello?
would as well. I agree.
I would
Because,
also do that. I
I'm
don't see why we wouldn't.
Yeah.
And I think that we would need to use it. And you would probably think that all the 22 weekers would need, but you never know what you will find, right? And we don't have anything better. So
Okay.
Thank you so much. I'm so grateful.
Thank
God
you.
bless you all. Everybody have a
Thank
good
you.
evening.
thank you,
Thank
Allah.
you.
Thank you very much.
Thank you.
See you
Thank you. Thank you.